Dr. Ben Thrower and Dr. Aaron Boster will be presenting this next great program that, again, we came up with the idea to do it. We gave them things that we would like them to cover, all about the immune system, obviously. And this is going to be very interesting. So Dr. Thrower is at his office and at the Shepherd Center in Atlanta, Georgia. And Dr. Boster will be coming on stage in a minute. And you know that he's with Boster MS Health right here or the MS Center right here in Columbus, Ohio. For everybody online, I hope that you can pay attention to this. It's going to be about 60 minutes long, followed by we'll do about a 45-minute Q&A. Again, today's program, our title sponsor is Bristol-Myers Squibb. Our silver sponsor for today's program is Sanofi Genzyme. We want to thank them both for doing what they did, all right, and to help make this program possible. All right, Dr. Thrower, you ready?
I am ready.
Great. Dr. Boster, come on down. He doesn't get to scream howdy today. All right?
Still.
He could still
Howdy, everyone.
There you go. Howdy. All right. So I'm going to let you two have it, all right? And I'm going to check back in about 50 minutes. I'll see where you're up to. I don't even know when you're ending, all right? And
we don't either.
You're having conversation with each other. So Dr. Boster is going to be looking at Dr. Thrower here, and Dr. Thrower can see Dr. Boster here. It's going to be a great Zoom call, as they call it, right? But we're not on Zoom. So everybody, have fun, enjoy, and let's take it away.
Thank you. So Stuart introduced me as Dr. Ben Thrower, but for the next 60 minutes and then for our Q&A, I am not Dr. Thrower. I am multiple sclerosis. And I've actually worked with physicians like Dr. Boster for many years and healthcare providers like Megan for many years. And so most of you should know me. I'm multiple sclerosis. I've lived with you for many years, but perhaps this is just one persona that I have. I have many faces. I have many presentations. I am the great mimicker. So I want you to get to know me a little bit better. So Dr. Boster and I are going to have a conversation. Again, we've known each other for years. I respect Dr. Boster, but I've got to say, I'm also, you know, the healthcare community is making my life a little bit miserable. Programs like this make my life very difficult. I would much rather you not be aware of me. This is MS Awareness Month, and while I'm flattered on one hand that you're aware of me, I would much rather you not be aware of me. I would rather healthcare providers and insurance carriers just leave me alone. Let me do my thing. I've been part of humanity for over 2,000 years. I'm part of a bigger family. You may have met some of my family members. I'm part of the autoimmune disease family. Rheumatoid arthritis, lupus, Sjogren's disease. These are my brothers and sisters, and we all share one thing in common. We love picking on the human body. So with me, multiple sclerosis, I love picking on your brain and spinal cord. It's my job in life. I don't mean to brag, but 1 million Americans are affected and live with me. It used to make me laugh a little bit when for years it was said that 400,000 Americans were living with me. I was amused and a little bit offended. I was really working hard to affect more human beings, and we know now that I affect at least 1 million people, and probably more than that. There are people that I live with that are just unaware that I'm even there. Again, I don't mean to brag, but I am the leading cause of disability in young American adults. If you take out trauma, I affect more young American adults and lead to disability than really any other health condition. So, you know, the human immune system is just fascinating. You guys have an amazing immune system, but it also gives me so many opportunities. And I'm going to talk about some of the things that I can do to screw up your immune system. And unfortunately, Dr. Boster is going to talk about the things that you guys are trying to do to push back on that. I wish you wouldn't. You're making my life really difficult. You humans have an interesting genetic code. You can't pick your parents. So part of what invites me into your life is genetics. There are over 200 genes that play some role in letting me into your life. There are environmental factors. Miss Smarty Pants Megan talked about vitamin D levels, and and we know that that's part of the issue. So a lot of you have low vitamin D levels, and that does play a role in inviting me into your life. viruses. I have some buddies out there, things like Epstein-Barr virus. Yeah, the Epstein-Barr virus is one of a number of viruses that might play a role into letting me into your life. So Dr. Boster, what do you think? So, what do you think about the genetics and Epstein-Barr virus? Have you guys learned anything or that you're going to do to make my life more difficult still?
So, Ben, it's nice to not meet you. This is an interesting conversation, and I was introduced as Dr. Aaron Boster. Today, I'm playing the role of the human body, the nervous system, and the person receiving what this MS is trying to give. MS is something that I didn't ask for. I didn't know I was going to have it. No one else in my family seemed to have it. And right when I was getting ready to start my adult life, in my late 20s, early 30s, right as I was thinking about things like work and family, I started to have problems, and I tried to hide them, and I couldn't hide them. I couldn't see out of an eye, but I could just fake that. And it got better, and so I didn't tell anyone because I'm tough. And then I started to have trouble with my leg and, if I can be honest with you, with my down there's. And that's when I decided it was time to go see attention. And I had to see some really expensive doctors that were very annoying, and they did mean things to me. They stuck a needle in my back. They gave me a really bad headache. And they put me in a tube, and it was really loud. And then they said that I had multiple sclerosis, and I never ever heard of that term before. And I thought I had something like myasthenia gravis or some other condition. And so I didn't know what MS was, and it was really, really confusing. And they told me that I was going to have to take medicines and gave me a bunch of packets and told me to go home. And so today, I'm going to try to grapple with this guy, and I'm going to bring to bear a bunch of team members and friends and families because I'm not going to do this by myself. And so I'm going to bring to the table some doctors, some nurses. I'm going to bring to the table some pharmacists, some nutritionists. I'm going to bring to the table a physical therapist. I'm not doing this by myself, and I'm going to beat the crap out of you if I can. So yeah, let's go ahead and get into it and kind of see where we end up. But I don't like having to share a table with you, MS. You asked me about genetics. We don't get to pick our genetics. You know, I didn't understand that MS has a genetic role to it. And so apparently, if you have MS, then your first-degree family members, so like my kids, my siblings, they have a 1 in 40 risk of developing MS, which is a lot higher than the general population in Ohio, about 1 in 350. All right, so real quick MS. I clarified that although I was introduced as Aaron Boster, I'm not. I'm going to represent the human body impacted by this nasty disease. And I shared a little bit of my backstory, so you missed that, but that's too bad for you. And in essence, I said I didn't know that this was going to happen to me, and I didn't understand what it was, and it was scary. And I'm not going to take it laying down. So I decided if we're going to have a conversation, I'm going to bring a couple doctors with me. I'm going to bring a nurse. I'm going to bring a clinical trial coordinator. I'm going to bring a physical and occupational therapist. I'm going to bring my family. So I'm not going to take it laying down.
You're ganging up on me. That is not cool. So
I'm going to bring a SWAT team to a knife fight, MS.
You know, so Megan talked a little bit about your immune system and how intricate it is. So one of the things that I love doing is screwing with the T cells. So, you know, your immune system was designed to protect you from the environment. It was designed to protect you from bacteria and viruses and maybe precancerous cells that pop up inside of you. But I have learned to turn that against you. So I have learned to turn, let's start with your T cells. So your T cells part of this army of the immune system. And so as Megan said, I love screwing with your T regulatory cells, with your Th1 and your Th17 cells. So what are you going to do about that? So I love just turning you on yourself.
You know, my immune system is intended to fight off bad guys, right? And really, I don't appreciate it attacking myself. And normally, there's this really nice balance between T cells that are inflammatory and sassy and like to get in bar brawls, and then T cells that are like regulatory cops that tell everyone to sit down and please be quiet and walk single file. And the human body is supposed to have this nice balance. But in the setting of my body with multiple sclerosis, my immune system is not like your immune system. I have an overabundance of inflammatory cells, and I have a paucity. I lack adequate regulatory cells, COP cells. So in my body, there's a misbalance, and that results in him attacking me. And so there's a lot of different ways that I can try to improve my immune system. We learned earlier from this amazing nurse practitioner down in Florida, Megan, talked to us a little bit about how through efforts of exercise, through efforts of clean eating, and through diet and healthy living, we can actually have a positive impact on our immune system by making it less inflammatory. And so that's one of the things that I want to try to do. I don't want to do things to my T cells like smoke cigarettes and cause them to be more pro-inflammatory and get riled up. And I need to be very cautious to take into consideration when I get an infection, because my immune system gets overly active. Now, fortunately, doctors can give me medicines that will alter my T cells. And so I have a lot of ways of combating you. For example, I can use a medicine like an interferon injection that I take once a week or a couple times a week, and that will tighten up my blood-brain barrier so your naughty T cells can't get into my brain. Because if they can't get in my brain, they can't attack me. And similarly, I can use Tysabri. Whoops, I'm not supposed to say names. I can use this monoclonal antibody that rhymes with my Mabry in the vein once a month. And that drug does an even better job of blocking my blood-brain barrier. So I could block T cells that way. I could also try to retrain my T cells. I could take one of the injectable medicines that rhymes with Mamaxone, and that drug will teach my T cells that myelin's not so cool. So I might be able to take care of it that way. I could even make my T cells not get adequately excited by killing my B cells. And then my B cells won't tell my T cells that you're there and that they should attack me. So I have a lot of different ways that I can try to alter what you're doing to my T cell or cellular immunity. Ha!
So one of the things I thrive on, it makes me very happy, is misinformation. I like for you humans to be either uneducated or poorly educated. And one of my favorite things, I love to hear this, is that your immune system is underactive. Isn't that true? You people with MS, you have an underactive immune system. Isn't that the truth?
That's a really good point that he's trying to pull the wool over on your eyes. So with multiple sclerosis, my immune system is not suppressed. I do not have a suppressed immune system. With multiple sclerosis, I have an autoimmune condition where my immune system is hyped up. It's overly active. So I tend to get infections less often than people in my family. I tend to not get the cold as frequently. My immune system is revved up on high. This misinformation that he's talking about is really important because it can lead us to make wrong decisions. Now, I do want to point out, because he won't tell you this, that sometimes the medicines that I have to take, the medicines can suppress my immune system. So my MS does not suppress my immune response, but my doc may have given me a drug that does that. And so I think that is important, and I want to make sure that I'm aware of that and not being fooled.
Fine. So Epstein-Barr virus has been one of my buddies for a while, and I heard a nasty rumor that some guys out at Stanford might have made some discovery recently about Epstein-Barr virus and antibodies. It sounds like just a bunch of mumbo-jumbo crap, and surely it won't lead to anything important, but what's going on there?
Fortunately, you're so wrong. We for the longest time didn't understand how you did what you did. We didn't understand how you got started in my body. And recently, a bunch of really cool scientists did something amazing, and they proved an interesting point. What they did wasn't mumbo-jumbo, sir. They took 10 million human beings in the United States, and they monitored them for Epstein-Barr virus, EBV, mono, the kissing sickness. And what they found was 95% of the general population, we're talking about 10 million people, had exposure to EBV. But the folks in the population that had MS, all of them but one, so like 99.999% of them had EBV. And when you deal with numbers like 10 million, that is statistically significant. And it helps prove something that we thought for many years now, that part of the process for me to get MS is that my body saw the infection EBV, and it fought the EBV infection. My immune system fought it off, but my immune system made an error in judgment. And when it built an arsenal, when it built the army against EBV, that army by accident identifies my brain as a foreign invader. So that's how you got in. And so now that I know that, I think there's a lot of exciting investigations. looking at how can we prevent that from happening. Imagine a world where we immunized people at birth. We gave them a vaccine against EBV, against mono. Just like we give vaccines against hepatitis and we give vaccines like against rubella and measles and mumps. If we gave them a population of infants an EBV vaccine, I wonder whether or not there wouldn't be any MS in that population. So you may not have a very good time of it as we start to understand this stuff.
Whatever. All right, let's move on. How about this? So Miss Megan talked about B cells in the immune system. And so I love, it made me so happy when for decades and decades, humans only focused on the T cells. Everything was all about T cells.
We were really wrong.
I got to screw with the B cells, and you guys kind of ignored all of that. So I love messing with the B cells too. Obviously they're a big part of what you guys do to fight back against me. So what's going on with any B cell therapy? Surely you don't have anything that's going to work there.
So you had a leg up on me for, a couple hundred years. And for the longest time, the doctors that took care of me thought that you were just about T cell problems, and that if we addressed T cells that we could beat you. And that was false, and we were unsuccessful. But we discovered something awesome that really came into play maybe about 10 years ago, that there's another side to the adaptive immune system. Not just T cells, there's also B cells. By the way, they're called B cells because they're born in my bone marrow. B for bone marrow. T cells are called T cells because they go up into my thymus, T for thymus. So these B cells that are in my bone marrow, they play a role in my immune system. And it turns out they're very involved in this MS process that you keep bragging about. So the T cell is the bad guy that attacks me. The T cell goes into my brain, thinks it's looking at EBV and attacks my brain, thinking it's a foreign invader. But the T cell can't do it unless the B cell gets it riled up. The B cell's like its friend that says, go ahead, whoop his butt, I got you. And what we've learned, much to your chagrin, is that if we murder the B cells, if we remove all the T cells' friends, the T cell is inadequate by itself to attack me. And so I can actually make you rather boring and ineffective if I simply murder the B cells and leave the T cells alone, because then they can't do anything. And now that I know that, I'm so excited that we've developed multiple therapies that deplete B cells or alter B cell biology to my benefit and to your detriment.
So I've heard some of your buddies, some of your neurology and nurse practitioner and other medical professional buddies say something that's really offensive to me, and you just said it, and that's you want to make MS boring. I'm a fun guy. I love to create havoc and chaos. What the heck are you talking about, making MS boring? What does that mean? I'm really offended.
I'm glad, and I don't share your opinion that you're fun. The human body's experience with MS is one of not knowing what's going to happen. And waking up in the morning, I got to check to see if both arms work. I got to check to make sure my legs work. I want to make sure I can see out of both eyes. It's a really big deal waking up. I don't like that. So I would rather have a life where I got to pick what I did and you didn't get to pick it all. And so I like the idea of making my MS boring. And what I mean by that is I don't want to have unexpected, unplanned events where you take away my left eye or the feeling in my arm or so on and so forth. I don't want attacks. I want you to be boring. I don't want to have new brain damage show up on my MRI where my doctor is pointing out new enhancing lesions and showing me damage to my thinking and memory organ up here. I don't want that. I don't want to have a loss of function and have trouble walking. I want to live my very best life. I want to choose what I think is exciting, and I don't want you really get to pick. And in 2022, if I listen to Megan, in 2022, if I pay attention to exercise as part of my lifestyle, if I adhere to a healthy diet and supplement low levels of vitamin D because I live in Ohio and there's no sun here, if I avoid exposure to smoke and I take one of the medicines that my doctor's giving me, I stand a chance of making you very, very boring.
Oh, where's the fun in that? All right. So I've screwed with your B cells. I've screwed with your T cells, but those those cells have to get into your central nervous system. And so Megan mentioned this. I love having an open door to your central nervous system. And so that blood-brain barrier, that leaky door that gets in, certainly you can't do anything about that. You might have some therapies that they play around with the T cells and the B cells, but you've got an open door to your brain, and I am walking right through.
So there are some things that I can do. So you're right that my immune system lives in the bloodstream, in the periphery. And so it's got to cross my blood-brain barrier to enter into my brain before you can do anything. And there are things that I can do to tighten my blood-brain barrier. You're wrong. So as I mentioned earlier, the interferon medications that have been out since the early 90s tighten my blood-brain barrier. It makes it really, really hard for you to get in. I can take medicines like that monthly infusion, and that makes that barrier even tighter. It makes it really, really hard for you to cross the barrier. And so I can do some things to tighten that up. It's an important way that I can prevent you from gaining access to my brain. There are even pills out nowadays, the S1P1 receptors, that trap many of my cells in my lymph nodes, because if they're trapped in the lymph node, they can't get in the bloodstream. And if they can't get in the bloodstream, they can't cross over the blood-brain barrier. So I can even thwart you just by trapping cells in my lymph nodes, taking medicines like words that rhyme with millennia.
So you guys, your doctor buddies out there, your healthcare professional buddies, they've come up with a lot of things. Life was so much easier for me prior to 1993 when we had no treatments out there. I got to do my thing. I was having a great time, but you guys have some therapies now. And it seems like your doctor buddies are developing things that could be more effective, things like natalizumab and ocrelizumab. Ooh, those sound really cool. But shouldn't you guys save those? Shouldn't you put those aside? You know, number
you would
one,
like that,
don't
wouldn't
start
you?
Right away.
So don't listen to him.
Save those.
So don't listen to what he's saying. He's asking you to fall into a trap that a lot of American doctors have fallen into, where we have low efficacy medicines that don't work very well in my body, but they're very, very safe. And so he would like me to start with those. He would like me to fail those medicines and spend time accruing disability and causing brain damage, because he knows if I use the better medicines early, it makes it harder for him. I fare better if I use the best medicine that I'm comfortable taking as early as I'm comfortable taking it. I don't want to waste time losing brain cells and losing spinal cord function because I took an undertreated arm. I took something that wasn't as effective as it could be, and you got a hold of stuff and you caused damage, so much so that my doctors could see it, and then they finally gave me the good stuff. No, I don't want to do that. I want to start on the most effective drug possible as early as I can, and that's going to work a lot better for me. So no, I don't want to wait. I'm going to start with that immediately.
Yeah, but you can only use those for a couple of years. I mean, you got to go off of that more potent stuff. You only use it for 1 or 2 years, right?
Nuh-uh. So these drugs now, so the drug that you mentioned earlier, Tysabri, has been around since 2004, and I have patients that have taken it since 2006, and they haven't stopped, and they're doing great. And we agree that we're going to stop if they die, or we're going to keep taking it as long as it keeps working. I can take these medicines as long as they're safe, and if my doctor checks and makes sure that I'm safe, then I'm going to believe them and work with them. And so I don't have to only take it for a short period of time. Moreover, if I can do a really good job on one of these big dog medicines that you mentioned, later when my immune system starts to quiet down, I can switch and go to a different medicine. But I'm going to ride out the high efficacy as long as I can. And you don't only take it for a little bit. You take it as long as it's working.
Oh, all right, fine. So you have a few tools in your toolbox. I'll give you that. But I have damaged axons. I have stripped insulation, myelin, away from nerve fibers in your brain or spinal cord. And no one has any interest in repairing that damage. It's never going to happen. One of your buddies out there, the National MS Society, they talk about some of the funding that they put towards neural repair. That's a pipe dream. It's never going to happen. There's no research going on into that. So we can just move on, right, from that. We're not talking about that.
So you thought there was no opportunity to impact the disease at all until 1993. There's 25 different formulations of MS medicines that I can beat you with, and they're all anti-inflammatory. And I'm delighted that you're even more wrong, because most of the research that MS doctors are looking into now is not in the realm of anti-inflammation. We have those drugs. I just talked to you about them. We're now excited because doctors are looking into other areas of MS care, like remyelination, like trying to stick the plastic coating back on the wires that you stripped off of my brain. And that research is very, very robust and exciting, and it's ongoing. And when the MS doctors go to these conferences, the majority of what they're learning about is remyelination and neuroprotection. That's the other thing. I think in order for me to live my best life with MS, I really ultimately will need 3 kinds of therapies. I need an anti-inflammatory, and that's like the medicines that you and I were talking about, the ones that I'm taking now. But I also need a remyelinating agent, and in addition, I need something that's neuroprotective. And those are things that we are working on. MS doctors think that we will probably have access to drugs like that within a decade. That's not that long away.
Oh. All right. So you want me to be boring, but I had a friend come to town about 2 years ago, and she is anything but boring. Her name's COVID. And so COVID and I get along really well. So again, I love misinformation. I love people to be scared and misinformed. And man, did my buddy COVID, she threw a monkey wrench into things. So you know, surely COVID has really screwed up MS therapy. People with MS, surely you have got to be at much higher risk for COVID. What are you going to do about COVID? She is chaos personified.
You're lying. So you're lying, because just because I have MS does not increase my risk to contract COVID. My ability to contract a virus is the same as any other humans, and I'm not at higher risk of getting sneezed on. And if I do get sneezed on, I'm not at higher risk of developing symptoms of COVID just because I have MS. Like I told you, my immune system's revved up. I'm not immunosuppressed. And so I'm not at higher risk of contracting COVID just because I have MS, and I'm not at higher risk of having a more severe COVID because I'm otherwise really healthy. My lungs work fine, my arms and legs work fine. I'm not at higher risk. Now, some of the medicines my doctors gave me do play a role, and I'll work with my doctors to deal with that. But I'm not at higher risk of COVID just because I happen to have you, MS.
But people with MS can't get COVID vaccinations because Megan said that some of the vaccines are contraindicated in people with MS. So people with MS shouldn't get vaccinated for COVID, right?
Wrong. He's lying. So I don't want to be injected with a live vaccine because my immune system could react poorly and it could actually trigger an attack. And so I want to avoid live vaccines. But the good news is the mRNA vaccines that were made for COVID are not live. And so they're safe to take. And they're not going to trigger a relapse in that fashion. So I can take them. And what we've learned is that these vaccines are unlikely to cause a problem, except for what we already know about the way that my body responds to vaccines, with any vaccine. But what they also know is that it will help develop my T cells and develop my B cells to fight off COVID, so that I already have some understanding immunologically of it. That way, if I come in contact with COVID later, I'm better able to fight it off.
All right, so fine, you can do a COVID vaccination, but there are some COVID therapies out there, monoclonal antibodies, some oral antiviral therapies. People with MS can't take those.
I can. Sure. In fact, if I've been given an immunosuppressant medicine by my doctor to treat my MS and I get COVID, I absolutely want to receive some of those monoclonal antibodies that I can't pronounce, like Bam Bam and other weird words. And I want to do that because it will hasten my recovery. And because of the immunosuppressant medicines that my doctors give me, not because I have MS, that I will benefit and I will recover faster because of it. And so if I get COVID, I have already spoken to my doctors and I know how I'm going to get those monoclonals. I know the local hospital that I'll go to. I know the path is laid out for me exactly in that possibility so I can fight it. I can take those medicines and I plan to.
So I heard a nasty rumor that, and this came from my good friend COVID herself, that some of your doctor buddies are actually giving some of these monoclonal antibodies to try to prevent her. They're giving those monoclonal antibodies to people maybe on a B cell therapy. That's just crazy talk.
No, it's not, and that's what we did. So there's a drug out there called Evusheld, which is 2 monoclonal antibodies, and I took it because I have MS and I'm on an immunosuppressant. And by having that for the next 6 months, I have drugs floating around my body that will fight off COVID if I come in contact. And that's in addition to my vaccine. So you can tell her to go to hell because I've got multiple plans to fight in case I come in contact with her.
Quite rude. All right. So let's shift gears for a second. Let's step back and just have some appreciation for some of the things that I do to you. Some of the symptoms. I mean, the wide array of symptoms that I can throw at you and just really make your life unpredictable. And 2 that I'm so proud of. And they kind of go unappreciated, and I'm kind of thankful that they do. I've worked really hard on fatigue and cognition. And I love it because your doctors sometimes don't even see them. Your family doesn't see it. They're things that screw with your life, and your own family members sometimes, or your coworkers, don't appreciate how much fatigue and cognition screw with you. And I've got to say, it's some of my best work.
I got to give that one to you.
Thank
the
you.
leading
Thank
cause
you.
of loss of work in the United States, I learned, is because of fatigue and cognitive impairment. So you're right that you do that really, really well. But I'm not going to take it laying down, and there's a lot of things that I can do to fight back. So first of all, being on an effective anti-inflammatory disease-modifying therapy has been shown to help me reduce my fatigue and my cognitive impairment. I'm also going to be paying attention, and my doctor screens me for cognitive impairment. So when I go to see them, they have me do these matching tests, and they tell me that's the way they can see if they're noticing problems. So they're looking. Supplementing my vitamin D and not smoking has been shown to slow brain volume loss. And so I'm going to maintain my brain volume. I'm going to preserve the neurologic reserve so I can keep it, because slowing brain volume loss correlates with better thinking and memory long term. I'm going to exercise as part of my lifestyle, which has been shown to improve cognitive impairment and improve fatigue and consolidate my sleep and slow disability over time. I'm a guy, and so I have MS. I'm going to have my testosterone checked. And if my testosterone is low, I'm going to supplement my testosterone, because that's been shown to improve my energy levels, and it's going to improve my thinking and memory. My doctor gives me a stimulant medicine that I take when I need it in the mornings before I go to work, and sometimes halfway through the day, that tricks me into being more awake. I learned from Megan that I can take levocarnitine, which is a supplement which can help increase my energy levels. And I became smarter because of you. So I know how to budget my time. I do my business meetings in the morning, and I take a nap in the afternoon, and I budget how much of the honey-do list I do each night so that I don't get overwhelmed. So yeah, you're good at it, but I don't accept it laying down. And there's some things that I can do to fight back.
So one of my other great little side hustles has been something called nerve fiber fatigue. So when I strip that insulation from your nerve fibers, the myelin, away, so I make those nerve fibers not work very well. And so about 70% of you humans have heat sensitivity.
Yeah, thanks.
A great idea of mine. So nothing you can do about that. You just stay inside in the summer, right?
No. So you're right. You do make it hard, because if I raise my core body temperature because I try to go jogging or because it's August in Ohio, my core body temperature raises, and then it causes me to short circuit. So where I had optic neuritis years ago, and that nerve isn't as good as it used to be, if I get overheated, I go blind again. And as soon as my body cools down, I get it back. Sometimes because I get overheated, my legs don't work very well, and I have trouble thinking. But knowing that, there's some things that I can do to prepare ahead of time. For example, there's a medicine that I can take twice a day, and I respond to it, and about a half of MS patients do, and it buttresses me against heat sensitivity. So when I go out in the heat, I don't melt. There's other things that I can do. I can be planful. I do my exercise in the mornings. I mow my lawn in the mornings. And in the heat of the midday, I don't go outside. I can make it work. If I want to go for a walk in the evening, I wait until it's getting close to sundown so it's not so hot outside. I hydrate with ice water because it cools my core body temperature. And I even use cooling towels, and I have a cooling vest in case I go to hot Atlanta so I can walk around with a cooling vest on. So there are some things that I can do to help prevent heat sensitivity and motor fatigue.
But those fancy cooling vests you just mentioned, those things are really expensive. Nobody can afford one of those. So unless you're super well.
So I love the MS advocacy organizations in the United States and abroad. And there are multiple advocacy organizations that will give me a free cooling vest. I submitted a request to the MSAA online, and they mailed me one for free. All I had to do is have a note from my doctor saying that I actually had MS. And every year they do that for people with MS. So if this one breaks, I'll get another one.
Okay, so fine. You've got a cooling vest now, but you mentioned something a second ago. You said when you exert yourself, you do a little bit too much, these symptoms come on. Aren't you causing new damage? You probably should be avoiding that exercise. I think exercise is bad for you.
Again, he's lying. So I can't cause my MS to get worse by exercising too much. So when I get overheated, my leg goes numb, but as soon as I cool down, my leg's fine, and it didn't cause damage. It doesn't cause any damage. So I used to be scared to exercise because I thought I would hurt myself. But once I learned that wasn't true, now I exercise with impunity. I love to exercise in the pool because it keeps me cool and pulls the heat off my body. But if I get overheated, it doesn't cause damage. And as soon as I cool back down, I'm back in the game. That's an important thing that I'm glad I know, and it helps me continue to work out and exercise despite you being on board.
So while we're talking about things you probably shouldn't be doing, here's one that I know that the females of your species who that I'm visiting with multiple sclerosis, clearly they shouldn't get pregnant, because I know for a fact I make symptoms potentially act up after pregnancy. So women with MS, your human females, should not get pregnant.
Nuh-uh. So that's not true. He keeps lying. So we now know that when a woman with MS becomes pregnant, her MS tends to get quieter, sir. And so if you think about it, the fetus, half the genetic material is not hers, it's someone else's. And normally her immune system wouldn't like that very much. And so there's a special situation during pregnancy when her estrogen levels go sky high. It protects the fetus against her immune system, but it also protects the rest of her body. And so, in fact, women are less likely to have disease activity in the second and third trimesters of their pregnancy compared to before pregnancy. And women can have a pregnancy. In fact, MS doesn't interfere with the ability to become pregnant or carry a child. And you don't necessarily get to visit the kid either, because the likelihood that they have MS is not super, super high. And there are things that we can do as women deliver children to help those children decrease their risk even further. So there's a lot that we know about how we can have children safely and successfully and minimize our risk and their risk.
All right. So you have these friends of yours, these healthcare providers, neurologists and people like Megan and physical therapists and psychologists. You really don't need all that stuff. You could just see a neurologist, and the neurologist could take care of all of this. Why do you worry about all those other team members? Doesn't it make life a lot more difficult? And you don't need all that stuff.
I don't do my own financial planning. I have a financial planner. And I don't do my own slaughtering of meat. I have a butcher. I don't take my trash to the dump. I have a trash man that comes. And so I live in a society where I leverage friends and family, and I create a village around me. And that's exactly how I'm going to beat you. And so sure, I could work with my neurologist, but I want to bring team members that can help my neurologist do a better job. So I'm going to work with a physical therapist who is a ninja at helping me walk. And that's all they're going to do with me. My neurologist isn't going to be able to do that, but they will. I'm going to work with a nutritionist who has a master's in nutrition to teach me the things that Megan was saying, so I know how to eat better. I want the biggest village possible, and I want to bring a SWAT team to a knife fight, because I am not going to allow you to become exciting. I don't want to allow you to make decisions in my life. And if I need to bring a urologist on to help my down theirs, I'm going to bring a urologist on. And if I'm having trouble with something that is involving my heart, I'm going to bring a heart doctor on. So I don't care how big my team is. I want the biggest team possible to whoop your butt.
but there's only like 2 comprehensive MS centers in the country. I mean, they're not that common. So, well, I mean, you talk about like this, like everyone has access to a comprehensive MS center. Surely that's not true.
So that's not true at all. There are amazing comprehensive MS centers throughout the country. There's a place in Atlanta called the Shepherd Center, arguably one of the very best comprehensive MS centers in the United States. My buddies work down there, and there are comprehensive centers throughout the United States. Ohio has 5. The Boster Center for MS is a standalone center and still brings comprehensive options to their patients. And so I think increasingly my doctors appreciate the need for comprehensive care, and they figure out ways to serve it up again and again. And you don't have to only go to UCSF or the Cleveland Clinic. There's a bunch of places where comprehensive care is offered.
So one of my other, we talked a little bit about some of my better projects I've done, messing with cognition and energy levels. Another one I'm really proud of is screwing with gait. So yeah, I love messing with people's walking. And 2 of the things I've really done a great job with is messing with people's sensory, their proprioception, their ability to change positions, feel changes in position, screw with your balance. I love foot drop. Again, really proud of that. And the great thing is there's not a thing in the world your buddies on the healthcare teams can do with either of those.
So I used to think that when I first got MS, I thought you messed up my gait, and then everyone would know that I walked funny until my doctors tuned me into ways that I can fix that. And so you're wrong, and I'm delighted to share why you're wrong. So physical therapists and occupational therapists can retrain my gait. They literally can help retrain my brain and spinal cord to make my legs move in a proper gait pattern. And when I walk now, I can hear them in the back of my head. Chest up, arms back, hands at your side, pick your chin up. And I remember those cues, and it helps me walk better. They gave me exercises that I do on the daily. I stretch on the daily, and those things can be very, very helpful. You made it so that my foot drops, but I can wear an ankle foot orthosis, which is just a cheap piece of plastic I put in my shoe, or if I can pull it off, a Bioness that can pull my foot up, and so the turf monster doesn't grab my foot. There's a host of things that I can do to combat that. I can even have physical and occupational therapists see me continually throughout the year just to maintenance, to keep myself going. I don't have to let you do that. I also have become smarter. So in the beginning, when you affected my joints, I didn't know where my foot was in space, and I used to fall a lot. But I've gotten smarter. At night, if I need to pee, I turn the lights on before I go across the room, and that way I can see where my feet are. I don't walk on uneven ground anymore. You might have taken that away from me, but I can walk on the sidewalk, and I don't fall. And so there are things that I can do to combat that, and I do them all the time. I'm not proud, and if I need to use a cane, I'll use a cane because I don't want to fall. My doctor is so in tune with this, they even check my bone density to make sure that my bones are strong, so if I do fall, they don't break. Na, 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 na.
Okay, so you've got something you might push back with walking on bladder. So, I love the way that the human bladder should work and how I can screw with that. So I can make it so that your bladder is small and overactive, and you've got to pee every 30 minutes, and maybe you make it to the bathroom on time, and maybe you don't. Or maybe I make you have a large underactive bladder so that your bladder's never emptying. Really unhealthy for your kidneys, puts you at risk for urinary tract infections. And then a special little kind of sprinkles on the top of that cupcake is I can give you something called bladder dyssynergia. I can make it so that you feel like you have to pee, and you go to the bathroom and you say, I know there's something in there, but there's nothing coming out because your sphincter's not opening up. What are you going to do about that?
Yeah, you're pretty good at that. It's true. But my doctors are smart, and there's pills for those ills, they told me. There are medicines that take a small racquetball bladder, and when I take them just once a day, they extend my bladder and relax it so it's a normal size, and I can finish an entire Coca-Cola and casually walk to the bathroom. Those medicines are really, really good at the first thing, and they don't address the second thing where the bladder neck is tight. But I have a separate medicine that I can take for that opens up my bladder neck. And so I might need to take 2 pills to deal with that problem, but now I can control my bladder much better, and I don't have oh no accident moments, and I'm not getting UTIs anymore because I still have urine in my bladder. Now my doctor said if that doesn't work, there's other options. He said that he can do Botox in my bladder and that I might not even need a pill. He said that if the pills didn't work for emptying my bladder, that I could use a catheter. There's a bunch of stuff that I can do because my goal is to be able to go out in public and not be wet. And so I'm going to do whatever I need to. And right now I can take care of that with 2 little pills.
Why don't you just make it easy on yourself and just not drink so much water? Why don't you just dehydrate? Then you don't have to pee all the time. Problem solved.
So again, he's trying to trick you. So I used to think that was a good idea. So I would say, oh, I have bladder problems. I'm just not going to drink any fluid. And what ended up happening was it made my bladder worse because the amount of urine in my bladder was super, super concentrated. And so it irritated my bladder wall and caused it to spasm. It also was a great place for me to store bacteria. And so it turns out by drinking lots of water the way that I am right now, I'm constantly flushing my bladder, and the bacteria and the toxins are diluted, and it makes my bladder work much better. So you're wrong, and I don't like your advice. It's backwards. The more water I drink, the better off I do. And I also learned to drink most of the water in the first half of the day and to stop drinking water around dinner time so that I'm not making urine at night and I get good sleep. So you're not going to mess me up there either.
All right. Well, at least with all of the things that I've thrown at you symptom-wise, one thing I have never done to you, and you got to give me credit for this, is I have never caused you any pain. So thank me for that, at least.
Dr. Boster attended medical school and was told by his professor that MS didn't cause pain. His professor was wrong. So you're wrong. MS causes a lot of pain, and you cause pain in ways that people can't see. Your pain is evil because it's invisible. And so you can cause me pain because my optic nerve gets swollen, and when I move my eye, it hurts like the dickens. You can cause me pain because I get a spinal cord lesion, and when I bend my neck, you send electricity shocks down my back. You can give me the only hug I don't want, the MS hug, where my ribs cramp down and I feel like I'm being squeezed. You can make light touch on the down there's hurt, called dyspareunia. You can make my thalamus damaged, and it can make it feel like my leg is on fire. So there's a lot of pain
that may be beyond my abilities at the moment.
You know, I will tip my hat to your medical folks. Again, my life was so much easier before 1993 when there were no treatments. You guys have come a long ways. I got to admit, I have a plan B. You know, you humans have retirement plans and things like that. I did buy a condo in Miami just to go sit on the beach because, maybe you guys are better than I thought. And so I've had a pretty good run for 2,000 plus years. Maybe there will be a day when I don't have a place in the human race anymore. And so hats off to your medical providers. But until then, we'll keep doing battle. I guess we can throw it open to questions now from the people in the audience and see what else is what thoughts or questions they have.
Fair. I'm not going to stop fighting you.
Hey, thank you, everybody. Thank you, doctors. Dr. Thrower, MS, and Dr. Boster, the human body. I want to thank you for making my dream come true of putting this together, this idea. I definitely could not have done without the two of you. So I want to thank you for that. That was awesome.
Ben, that was a lot of fun, friend. Thank you.
Thank you.
That was so much fun that I'm getting text messages from a lot of people and telling me what an awesome idea this was. So I'm glad that you all thought so. So for those online, please remember, you have been typing in your questions. Please continue typing them in. For those in the audience, if you have any questions, please raise your hands now so I know where I'm going to. All right, and then we're going to get the ball started here with asking questions. All right, again, thank you. Where are you? You're right there. Thank you, Dr. Thrower. And thank you, Dr. Boster. And let's go forward with this. All right, any questions out here? I see in the back.
Hello. My question, I know we have temperature sensitivity, and I know about the heat, but I've had issues with the cold this year.
Now, out of geographic respect, I will take this question because Dr. Thrower lives and works in Atlanta, Georgia, and so he only understands by reading books what we experience up here in the Great North.
Chilly here. Hey.
It get cold there too, just not
No,
as.
I know. Jokes aside, it's true that people impacted by MS can have difficulties when they get overheated, but many of our patients have difficulties when they get cold. And what we typically see when someone gets cold is they can have increase in what we call spasticity. Spasms, cramps, Charlie horses, limbs that are hard to bend get worse when it's cold outside. And when I say cold outside, I don't mean like you're in an ice box. I mean like it's just less than 60 out. Even a change like that we Ohioans may see like in October is enough that we start to need more intervention for spasticity with increased doses of baclofen and stretching and so on and so forth. Very, very common problem and very frustrating. Up here in Ohio, it'll be 70 one day and 30 the next, and that wreaks havoc on our bodies.
Great, thank you for that. All right, I'm going to take questions from online, and you guys are going to have to take turns between MS or other, and who's going to answer these. Okay, thank you. There's a ton of people online that we're watching that are all writing how awesome, creative, genuine, genius, and whatever you guys are, and thank that we were able to put this together. But yes, you could both wave. All right. All right. I'm back here in the what we created our studio booth, so I could ask these questions. All right. Which is worse, T cells or B cells in lessening progression?
So it's not that one is better or worse. It's that every individual with MS probably has their own unique immune profile. So there was work done at Mayo Clinic years ago where there was something called the Lesion Registry Project, where they were trying to look at how your individual MS works. And there probably are individuals out there whose MS is maybe a little bit more T cell driven, other individuals a little bit more B cell driven, people who have some of both. We are getting closer to the day when we will have customized medicine. So it would be great if we could do a blood test and say, this is how your individual MS works, and we're going to design a customized therapy for that. We're not there yet. So we try to pick therapies that have the greatest chance of fitting your lifestyle, of fitting what your goals are. But we also realize that we're not at the point where we know exactly how your individual immune system works. So it's not that overall we can say T cells are the bad guys or B cells are the bad guys. They all play a role, and in the individual it may be more towards one or the other.
What he said.
Great, thank you. All right, for anybody in the audience that has a question, please raise your hand, get my attention, and then I'll stand up, and she can wait. But she works with the organization. She can wait a little bit, all right? But anybody else, raise your hand, get my attention. I'll get up and get over there. Meanwhile, those is like 50 questions online, so I'm going to continue with these for now. Well, a person asked why the doctors had different opinions. And actually, it wasn't that they had different opinions, but that one was playing multiple sclerosis. You want to take a bow, Dr. Boster? Dr. Thrower? There you go. Sorry about that. That's an MS moment. All right. Next, and the other doctor was playing the human body and what it feels from getting hit with MS and giving its answers on everything. Okay? All right. Next, we have, what do we have? It's hard to see this. Can you give the name of the medication that's used to reduce heat sensitivity?
So 4-aminopyridine, or 4-AP, is the generic drug. In the United States, the on-label name is Ampyra, and in Europe, that same on-label is called Fampyra.
Okay. Next, a person wants to know why Dr. Thrower didn't have... Okay, I don't understand that question. All right, we got to find something else. Tell us more about the medications for the urinary problems, please.
So we have probably more tools in the toolbox for the small overactive bladder, so they got to go right now. So you have a class of drugs called anticholinergic therapies. These are your detrols and ditropans and all of those things. There are multiple options there. The challenge with those medications is those chemical receptors in the bladder that those drugs work on are not just present in the bladder, they're present in your salivary glands and in your GI tract. So we can usually help that small, overactive, gotta go bladder relax. We want to do it without giving you horrible dry mouth or constipation. If that class of drugs doesn't work, we have other medications, things like Myrbetriq. Usually your insurance company is going to want you to try one of the old school drugs. And in fairness, they do work for a lot of people. They're a little bit less expensive than the newer options out there. So those are the things that we have in the toolbox for the small overactive bladder. The large underactive bladder, as Dr. Boster was saying, we have things that maybe help that urine flow out a little bit more effectively. A lot of times these are drugs that are sometimes used for guys with prostatic hypertrophy, so we're just trying to let that urine get out a little more effectively. It's really important that we keep that bladder empty. If your bladder has more than 100 cc's of urine in it all the time, the two things that Dr. Boster mentioned, we don't want to see happen. We don't want you to hurt your kidneys. We don't want you to be at risk for urinary tract infections. So sometimes we do need to get a urologist involved. We may have to talk about intermittent self-catheterization because we've got to keep that bladder empty. Botox can be something that we use to help out with some of those bladder symptoms. And then there's a surgical device or surgical surgery called the InterStim. If you can't get signals to your bladder from brain through spinal cord, what if we just bypass all of that and put a little pacemaker surgically implanted to send a signal through the nerve roots to the bladder? There are neurourologists can, if that was appropriate for you, they can help you kind of to talk about the risks and benefits, who might be appropriate for that therapy.
If I piggyback off the master's class answer that you just received, that was awesome, Ben. I just want to throw in a shout out to pelvic floor physical therapists who aren't a medicine, they're a therapy, and it's a game changer for a lot of people because we find that the down there's, the pelvic floor becomes weak from disuse, which can have an impact in bowel, it can have an impact on bladder, and it can have an impact on bedroom. And so I like to add in a little pelvic floor physical therapy love into the mix.
Yeah.
Okay, next. Thank you, guys. For those that, there are a lot of people asking if this is being recorded. The answer is yes. So it'll be on our YouTube channel in hopefully less than a week. And yes, the MS Views and News. MS Views and News does have a YouTube channel. For those that didn't know, we do have that. There's thousands of recordings on there that we've done from programs over the last 10 years. Okay, so the next person is saying this fight gets exhausting. And I always tell people it's like a part-time job, even though I still have a job. Will there be a time when there is a provider who can better coordinate our care? It's a lot of work for those with MS and can't be done as well as if I even tried. It's hard to do all the things we're supposed to be doing while working and trying to have a normal life. What can you both say about this, please?
You want to start?
Sure. So we talked a lot about that comprehensive team, and it is so important that you have a comprehensive team approach. So one of the things I learned early in my MS career is that my neurology piece is important, but man, I need some help. And so ideally, you're going to be working in a center where you've got case managers, physical therapists, occupational therapists, and there's another part that kind of complements comprehensive, and that's integrated. You want a team where all of those team players talk to one another so that the therapists are coordinating with the neurologists. There are examples of systems where you could have comprehensive care, but those pieces of the puzzle are not talking very well to each other. At the end of the day, be your own best health advocate. If you're not getting what you need wherever you're at, go somewhere else. And if you live too far from a comprehensive integrated center, sometimes what we have folks do is just visit once a year, maybe. So you go in, you get a game plan. That team is somewhere like the Boster Center is coordinating with your community back at home, so that you just use the pieces of the puzzle in whatever way fits best for you.
That's a really important point, and I want to piggyback off that and say that we didn't build Rome in a day, and we're not going to optimize you in a day. And so it can feel overwhelming, and what I recommend is working with your team, identify the priorities. So for example, when I first meet a family, the biggest priority early on is education, because they need to understand what the hey we're doing. And that education is the beginning of a long-standing relationship of teaching. I want to get them on the most effective drug that they're capable of getting, and then I want to start to pick away at their symptoms. We might not get to address all their symptoms, even in the first year of care, because there's so much going on. But that doesn't mean that we don't approach it. And what I like to think about is each clinic visit, each opportunity with a team member, we're gonna chip away at MS's hold on you. And it's a marathon, not a sprint. And so you don't have to get it all right like in the first week. And I think having that mindset is also helpful as you work and build your team and as you work and become your own best self-advocate. I think that's an important piece.
I just wanted a thought to put in a plug for Stuart and his group. So Stuart, you helped put together this great tool for people with MS to use and helping prepare for their provider visits. So it's important that when you go in to your provider visit that you know what the priorities are. So what's going on in your life. It helps us a lot if you come in prepared. You've got your medication list, you've got your question list, you know exactly what you want to get out of that visit. I love looking at someone's list ahead of time, because things that you might think are separate issues, we may look at it and say, you know what, question number 1 and question number 4 and question number 7 really are part of the same issue, and we might lump those together and address those. If you don't make a list, make sure you put your most bothersome issue at the top of the discussion. And it's human nature. We have limited time in these doctor visits, provider visits. And sometimes people will save their most pressing, bothersome thing for the end of the discussion. Don't do that. Put it up front, because you want to make sure your most important thing gets addressed first off.
Dr. Thrower and I, in preparation to receive you in our clinic, prepare. So before you have clinic with me, I read through the chart. I look through your last couple notes. I oftentimes pull up your MRI. I know everything I want to ask you, and I'm ready, and I've reviewed everything we're going to talk about. I'm doing homework in preparation for meeting you. I think it's only fair that you meet me halfway and that you're also prepared. Failure to do that doesn't mean we're not going to win, but it's going to take a lot longer. And I want to be able to use that time effectively as a team. And so you getting ready is really important. And Dr. Thrower brought up a fantastic tool that MS Views and News has created. It's free online. It's a form you fill out and you just complete the form. And if you answer all the questions on the form, you're almost guaranteed to be ready to talk with me in your clinic visit.
Thank you, guys. And to benefit, and I'm going to piggyback on that one, all right?
That's a lot of pigs.
That's a lot, all right? And for, this guy's kosher, so that makes it more difficult. All right. So anyway, if for those that go to our website and find that tool to use online, you can either just print it out, fill it out, and bring it with you in advance, or send it in advance to your doctor. And for those who have difficulty using their hands, you can fill it out online. You don't have to. You can type it in rather than writing it. If your handwriting is that horrible, you could just type it all in. Okay, there may be 2 things on there that require you to circle. Of course, you can't type that. All right, but you can underline it. All right, and you can use that as, whatever to then just bring in. So you fill it all in online, click to print it off, and just bring it with you, okay? All right, thank you guys for that. All right, I'm going to take a question from this young lady over here who's going to kill me if I don't give it to her, and then we'll go back to the online questions.
There was some discussion about a remyelination medication that is in the works. I'm wondering what we can expect from that.
Go ahead.
So I'll put in a shameless plug here. So we're Shepherd Center. We are doing a mesenchymal stem cell study, and so mesenchymal stem cells are just one of a number of pathways that are being looked at for remyelination. So we know that the human body does have the capability of repairing myelin. One of the major questions is, why don't we do a better job of it? Other animal species do a much better job of fixing damage in the brain and spinal cord. We know that humans have cells called oligodendrocyte precursor cells. These are the cells that grow up in life to be oligodendrocytes and make myelin, and you've got a savings account of oligodendrocyte precursor cells in your central nervous system that you don't use. One of the questions is, why don't you use them? Why are you not repairing the damage in a more effective way? So there are areas of research looking at how you use those natural repair mechanisms. The study that we're doing is a phase 1 mesenchymal stem cell study. So we have infused the first 2 humans to receive this particular stem cell. Rocky Mountain MS Center in Salt Lake City has done the other 2 infusions. There's a center in Boston doing that. The National MS Society devoted a lot of money about 15 years ago towards neural repair, remyelination, repairing axonal damage. And a lot of that original research was focused on the lab animals, test tube models, but now it's starting to bear fruit into human studies. So I do believe it will happen, and realize that what we do in MS does not exist in isolation. Think about spinal cord injury. In the spinal cord trauma model, their whole world is about repair. How do we reverse that damage? And they only have one side of injury, and they don't have an immune system that's causing more injury, so they can devote all of their efforts towards that neural repair. So if something works in that arena, there's a pretty good chance it may work in our world as well.
Okay, no piggybacks on that? Okay, gotcha. All right, you're going to have a question. I'll be there in a moment, please. Thank you. A person is writing, notice I'm not saying anybody's names today, right? Can you tell us about depression? There was no discussion about depression in MS. Did you guys bring the guys up? Did you miss that?
We'll talk about it now.
All right. Can you add any info about depression and how this is affecting people and why so many are affected?
So people impacted by MS are literally twice as likely to experience depression compared to the general population. People impacted by MS are twice as likely to experience anxiety compared to the general population. People impacted by MS are at very high risk of something called social isolation, where by various reasons they're kind of taken out of the social community, and that can increase the risk for depression. If you take those background and then you add a global viral pandemic, if you tell me you're not depressed, I call shenanigans, because that's the only appropriate human response. And Ben and I are essentially junior psychiatrists in our clinic because it is so pervasive, the degree to which depression is an issue. Now, the good news is we can treat depression. And there are a host of very, very effective antidepressants. We're getting smart about how to use them in combination. Even dumb neurologists do that now. And that's not the only thing that we do is just pharmacology. Mindfulness that Megan talked about has been shown time and time again to improve mood. Exercise has been shown to improve mood. Cutting sugar out of your diet has been shown to improve mood. Cleaning up your diet has been shown to improve mood. If you work on fatigue, the discussion that we had earlier, that benefits mood. And so there's a host of things that can be done. It's my experience that if we treat MS's depression aggressively, we can be very successful in managing it. I do want to tell you something scary. Untreated depression in MS causes MS to get worse faster, like neurologically. That's terrifying. So a lot of times I'll hear a guy or a gal in my clinic say, well, I don't want to be treated for my depression. And I need them to know that I'm speaking as an MS doctor, needing not just to improve their quality of life, but to slow their disease down.
And to piggyback on that, we used to think a million years ago that depression and MS was just a natural human reaction to what MS was throwing at you. And so it was, the symptoms you were dealing with, it's the changes in family and vocation. And that may be true for some people, but it's also just part of the biology of MS. You have a lot more brain devoted to mood and cognition than you do to motor and sensory function. So it's not unusual to think that due to the damage in the brain itself from multiple sclerosis that you might have some mood issues. We think even some of the changes in the immune system, some of the inflammatory chemicals that are sort of overly abundant in multiple sclerosis may be associated with changes in mood. And Dr. Boster and I apologize that as the MS guy that we didn't talk as much about mood changes. It is clearly, it's very, very important, and it impacts things outside of just mood. We think of cognition in MS and how cognition can be affected by mood and energy levels. A lot of folks with MS will say, my memory is really horrible. And when you start peeling it away, it could be a memory problem from their MS, but it could be underlying mood changes. If your mood is not great, there's a good chance that your attention and concentration are not great either. So how many of you you'll have a conversation with a significant other, and 5 minutes later, it's like it never happened before. And it's because you're not storing that information to recall it a little while later. And it may be because of an underlying mood.
We lost you. Ben, I don't know, we couldn't hear the very last sentence. I oftentimes in clinic refer to the up there's. The up there's, thinking of memory, energy, and mood. That's a triad of symptoms. And if one is bad, it pulls down the other two. And if one gets better, it lifts up the other two. And so what Dr. Thrower is talking about is very, very relevant to good MS neurology. If I see that you're having difficulty with thinking of memory, I'm obligated to explore your mood. And if I identify that you're a little sad, blue, and depressed, and I give you an antidepressant, your cognition improves, like you think more clearly. There's a fancy term called pseudo dementia. Pseudo is Greek for similar to, but it ain't. Mentia means think, and duh means you don't do it very well. So pseudo dementia is when you're having trouble thinking, but it's not because of a dementing illness, it's because of a mood problem. And so we improve life by addressing that triad of symptoms, and it doesn't ever happen in isolation.
Okay. Earlier, one of the two of you said each MS patient has their own unique immune profile. This is kind of a piggyback off of earlier conversation, and it leads into the mood, energy, memory piece. I also want to say that each patient or person has their own story. And with that, something that helps get me through personally is knowing as long as I have a pulse, I have a purpose. With MS or without MS, as long as we have a pulse, we have a purpose. So that's all I wanted to say.
It's beautiful.
Thank you.
Question. Do the medicines that we take depress our immune system?
Some of the some of the MS medicines we talk about disease-modifying therapies. Some of those medicines we call immunomodulatory, meaning they alter the immune system, but they don't suppress it. So those medicines do not increase risk of infection. There are other medicines that we take, disease-modifying therapies, that are immunosuppressants, and they work to treat MS by suppressing a component of the immune system. So with some of those medicines, there can be an increased risk of, say, infection. So really, it's not a one-size-fits-all, and it's actually even more complicated than that because some of the medicines indirectly suppress the immune response. And so your doctor can share with you this medicine is or this medicine is not an immunosuppressant.
And along the same lines, it's really important if you're on one of those medications that might alter immune function, and if your healthcare team says you need to get laboratory testing done as part of safety monitoring, don't skip that laboratory testing because you really want to dial in and let those medications do what they're supposed to do and not more than they're supposed to do. So even though you may feel well and you might be tempted to skip lab testing, don't do it. It's really important. It's just as important as any other part of your MS management that we know what those medications are doing in your immune system.
Okay, I'm sorry, I had part two. So yes, thank you for the answer about the medicines. Now, if I take special vitamins to make my immune system very, very strong, am I hurting my MS?
Yes. So fortunately, the health food store aisle that says immune boosters, fortunately those are untested and unproven, and most of them don't work, thank God. Because if they did work, it could cause your immune system to become increasingly overly active. The last thing on earth I want someone to do with MS is boost their immune system. And so that theoretically, if they did do that, that would be a problem. An example Megan gave earlier was echinacea. So echinacea is over the counter, you don't need a prescription, but echinacea can augment your immune response, which is a bad idea in the setting of multiple sclerosis.
Yeah, and we need to be, and I echo all of that, we need to be more sophisticated in the way we think about our immune system. Your immune system is not this monolithic, block that it just causes inflammation. There are parts of your immune system that are regulatory. So, for instance, with vitamin D, we know with vitamin D that it has the potential to upregulate something called T regulatory cells. So you could say, well, isn't that stimulating my immune system? Maybe, but it's stimulating only a very specific part that might be relatively underrepresented in MS. So I agree, when we think about vitamins that are broadly immune boosting, like in echinacea, I think we want to be really, really careful. Your immune system is not underactive. Your immune system is relatively overactive in a very specific way that's leading to this attack on the brain and spinal cord.
Okay, next question.
Are there any therapies to help with hand function in MS besides occupational therapy? I know Ampere helps with walking.
So the question is there anything specific for hand function? And she says, and I already know about occupational therapy. And so that is a huge first step, right? If somebody's having trouble with their activities of daily living, a lot of times that involves hand function, we're going to pull an occupational therapist to help us. You're right that Ampere was tested for walking speed. I don't have very many patients that are desirous of walking faster. Most of my patients are desirous of doing something longer. And Ampere doesn't only help walking problems. It helps any heat-sensitive issue or any motor fatigue issue. So I have some patients, if they use their, let's say they're writing for a long time, their hand function starts to peter out. Fortunately, some of them respond to Ampere. And on Ampere, they can continue to write. It's not always the case, but I have seen that several times. Yeah, so there's a lot of this.
It's one of the, I think, the unfortunate things with Ampere. When they did the studies, they really looked at walking. They had to, the researchers had to pick something, so they picked walking. But it's not the drug doesn't just magically work on nerve fibers to the legs. It can, like Dr. Boster was saying, it can work for your arms. And the old version, 4-aminopyridine or 4-AP, we never thought of that as a walking therapy. We thought of this as something that helped for any heat or exertion-related symptoms. It could be walking, hand function, cognition, anything could potentially respond to it. I think one of the mysteries with those types of medicines, the Ampere and the 4-aminopyridine, is why don't they work for everybody with MS? The sad fact is they don't. They work for about half the people, and you're usually going to know in about 4 weeks, which group you're in if you try one of these.
Now, if we take the specific example you give, she's asking about hand function. She's a computer programmer. There are a lot of adaptive measures that circumvent a problem with your hand. For example, Dragon dictation software is really, really getting savvy. So for example, many medical professionals can use Dragon dictation software, and it knows all of our weird words. I've worked with a lot of our patients to figure out the right mouse, because they were using a mouse that was causing their hand to spasm and cramp, and when they got a different configuration, it really made a big difference. And so even thinking about the ergonomics of your environment, you may come up with some adaptive measures that can work aside from just smashing the keyboard with your fingers.
Yeah, and there's a spinoff of, you mentioned occupational therapy. There's kind of a spinoff of that. It's a super specialized group of people called assistive technology. And so they're the folks that are going to work with you on trying to get your computer system set up so that you can use things like Dragon to the best effect. There's another technology out there, and it's very niche-y in terms of who it might help with, but we've had a handful of patients, pardon the pun, that it might help with, and that's so Bioness makes the unit for your foot, for foot drop, the L300. Well, they make a unit for the hand also called the H200. Again, it's very niche-y, and it probably is more applicable to people who've had stroke or spinal cord injury. But I've had a handful of people with MS that do benefit from the upper extremity unit.
As a risk of a sidebar, I want to share with you some exciting research outside of MS, but it speaks to the convergence of information. There's a research group in town called Battelle, which is this big institute, and they partnered with some local neurosurgeons, and they did something sensational. There's a guy that has a high spinal cord injury, so he can't move from the neck down. And they implanted electrodes in his brain, which they connected with wires to his arm, and he was able to do this. Even though he couldn't feel his arm, they trained his brain to circumvent his spinal cord. Now that is an N of 1 in the entire world, but my point is we're doing that. Like, I watched the guy. And so I think, to piggyback off something Dr. Thrower said a while ago, as we learn in all fields of medicine, the future is very, very bright.
You guys done with that? Should I go to the next one? Thank you.
Yep.
Awesome. All right. Next person asks, I've had change in recent MRI, and my doctor says that it's not due. My doctors say that it's not due to my MS. I can't get doctors to notate my difficulties. My doctors won't communicate appropriately to help me. So what should I do, and what do you recommend?
That's actually 8 questions. So let's start with the first question, which is a question about the MRI. So when you take a picture of a house and you see that there's a window shattered, you don't know why. You know where, bottom, floor, far left window is broken, but you don't know why. When you take a picture of an MRI and you see a white spot, you know where, and you know that it wasn't there last time, so you kind of know a little bit about when, but you don't know why. The way that we figure that out is not by drilling a hole through your skull and putting in a needle into that spot and sucking out that piece of brain because you might want it. Instead, what we do is we look at the shape of the spot, the size of the spot, the location, and what happens when we give contrast. And based on the way the spot behaves, we can have a better sense of, this is behaving like an MS spot. This looks like a stroke. This looks like a small vessel ischemic thing. This looks like a tumor. This looks like an infection. So when your doctor's looking at your MRI and says there's new spots, but it's not from MS, it's fair to say, can you please help me understand what you're seeing? And they should talk about, this spot is in the wrong space. It's in the wrong size. It doesn't behave in a way that and they should be able to explain to you why they think that.
And I, just to take that a notch further, so the MRI in MS is a great tool. It's a piece of information, though, and I think sometimes there's a temptation for us to get too hung up on what that picture is telling us and ignore what the person in front of us is telling us. And so the MRI can be disconnected from how you're doing as a person in a couple of different ways. Dr. Boster and I see newly diagnosed individuals who, their MRIs show a lot of stuff going on and they feel fine. Early on in MS, there can be way more stuff on MRI than what you're experiencing clinically. I think the bigger issue we're dealing with these days is the other end of the spectrum. The person sitting in front of you in the exam room and their MRI hasn't changed. It looks just like it did last year. And the person says, but I don't feel the same. I feel like my walking has gotten worse, or my cognition has changed. And I think the most important thing we can do is believe you. So we know that the MRI shows things, but it doesn't show everything. And so there is stuff going on that's probably below the surface, or even good 3T MRI scanners that we're using these days. We're probably only imaging some of what MS is doing to you. And so, we're getting better. We're getting better techniques. We're learning that MS damages deep gray structures, for instance. We're getting ways of potentially measuring that. But I think it still points out the need for us to ultimately step back and always put the person in front of us at the center of the discussion, not the technology. The technology should be a help, not the definition.
There are 3 ways in broad strokes that we're going to figure out if you're doing okay, or if we're winning, or if the drugs, whatever words you want to use to describe yay. One of the ways, and the most important way, is what you tell us. Dr. Thrower was basically saying, you're a you expert. Like, you know more about you than anybody else. So if we learn to shut up and listen, you'll probably tell us what's wrong. And I mean like 85% of the time. Now, the other way that we learn about you is, I would submit as a tiebreaker between the MS Olympics, when we bring you in and do all the functional testing, and then the structural imaging on the MRI. But the functional testing in the MRI, the structural information, buttress or support what you experience. The buck stops with how you do. And so his point is very important, that I don't treat an MRI. I've never given a drug to an MRI. I treat a human, and I use the MRI as one of the many, many ways we sort out how you're doing.
And Stuart, if you'll indulge us, just one other, because I think this is a great thing that topic, and people with MS struggle with this. We probably should talk a little bit about neural reserve, and so why that person who's says I'm getting worse and my MRI has changed, I think we're starting to understand more and more about neural reserve. Neural reserve is how much can you injure your brain or spinal cord and get away with it, whether it's an MS injury or a stroke. And so
alcohol,
Dr. Paul, alcohol. So the greatest explanation I've heard for neural reserve is if it's a lake level. And so, you know, the depth of the lake is how much you can injure your brain or spinal cord and get away with it. And we're all born with a certain neural reserve. As we get older, our lake level drops. It's human nature. Our brains start shrinking at about age 30. Humbling, but true. So when you think about MS lesions as like tree stumps, and some of those tree stumps are under the surface of the water. Some of the tree stumps are above the surface of the water. The ones that are above the surface of the water are the ones that are giving you symptoms. As we age and our lake level drops, some of those that were above the surface of the water are becoming more obvious. Some that were below the surface of the water are now becoming more obvious. So your MS didn't change. The tree stump didn't get any bigger. Your lake level dropped. And so that kind of circles back to that neural repair, idea. It points out the absolute importance of us finding strategies to repair the damage. We need to either put water back in the lake or we need to make your tree stumps smaller. And I think we're getting closer to that.
That was a really, really important master's class that he just gave you. That concept is something that MS neurologists did not understand even a decade ago, and it's driving our decision-making in clinic and in research. And it's super duper important. Just to help you understand it, all humans have a diminishing functional reserve. So when I was 18, I could skip a night of sleep, and I didn't care, and I would just sleep like the next night. In my late 40s, I'm exhausted saying that. It makes me tired just speaking it because my functional reserve isn't what it was when I was 18. And in the setting of MS, you can lose your functional reserve faster. So when we tell you that we want you to engage in brain health, not smoking, exercising, etc., it's not to help you today. It's to help you 20 years from now because we want to limit the brain volume loss and the atrophy. We don't want the brain damage to occur. Last comment, and then I'll shut up, is another way of thinking about it. If I blew a hole in that wall and we just left it there and like they put a note, neurologist lost it, blew a hole in the wall, people came and saw it when they went to they said, hey, can we have the conference in the room with the hole in the wall? And then we wait 30 years till this building has aged and the materials in the building have aged. Which wall falls first? The one with the hole in it. So we don't want the hole to show up in the first place. I want to give you the most effective drug as early as I can to prevent the hole from ever occurring, to prevent the tree stump from coming in the first place. We are trying to help you not so much for now, but for the 30-year down the line you. And we need you to think with us long-term like that if we're going to be successful. Because oftentimes we feel more tired or we feel worse than the young person newly diagnosed looks and feels. And we're not trying to help them for them. We're trying to help them for them later.
Okay. Thank you, guys. Next. This question is solely for MS. What do you think about high-dose steroids when you decide to attack me?
So high-dose steroids are a tool in the toolbox. And so we use them typically to treat relapses. And so we have to realize that high-dose steroids have risks and benefits. They can do great things. They can put the fire out of an MS relapse more quickly, but they don't come without risk. Even just the 3 days of IV Solumedrol that we typically use here in the United States, our Canadian colleagues would say we're weird for doing that. They would use high-dose oral prednisone instead, or maybe have you drink that bottle of Solumedrol with some orange juice. Regardless, however you get those high-dose steroids into your body, they're not risk-free. They can do things to your bone density, to your promoting premature cataracts, to your blood pressure, to your blood sugar. So it's always about that risk and benefit ratio. Most of the research out there would suggest that when we do high-dose steroids, what we're probably doing is we're speeding up your recovery. Do we actually change where you end up at? It's debatable. The old optic neuritis treatment trial from a million years ago would say, whether we do high-dose steroids or not, you're still going to recover to the same degree. We just get you there faster. there are other studies that would say, man, maybe if you've got a big, bad, ugly spinal cord lesion, we don't want to let that fire burn out on its own. Maybe we should put that fire out more quickly with high-dose steroids. Ultimately, though, the best way that we can prevent relapses is not to mop them up after they happen and worry about steroids. Let's prevent them from happening in the first place. Let's have you on the most effective therapy that you can be on to keep you from having a relapse altogether. Even if we decide not to treat a relapse with steroids, let's say that it's mild and there are no MRI changes, and we decide we're just going to wait it out. We still want to document it. So let us know if you're having what you suspect to be as a relapse, because we want to document it. It factors into the big picture of how effective do we think your therapy is.
Thank you. Next, did you guys discuss neurofilament light?
We did not.
Only indirectly.
So when we say NFL, we're talking not about football, but we're speaking about something that you guys are about to discuss.
So show of hands, who's familiar with the most famous doctor in all of Starfleet, Bones McCoy? Yeah, so many of you are familiar with Bones McCoy, and he's really a hero of mine. I look up to him, or at least I look up to the technology that he has, because he has this diagnostic device called a tricorder, where he flips it open and he scans the person, and he can tell them what's wrong with them. And Ben and I don't have that. And that tricorder is really a fictional version of something that's called a biomarker, where we can learn about you, but not from you. Like we can get a result of a blood test or a picture, and it'll tell us info about you. Right now, the very best biomarker we have to diagnose and monitor is the MRI. And Dr. Thrower discussed with you some of the limitations of that MRI. It's just a picture of structure. And so we really, really need better biomarkers to monitor this disease. And there's a biomarker that's been in development for many, many years, and it looks like it might hit prime time. And that's something called neurofilament light chain. So real quick, we've been talking about neurons. So that's the cell in the brain that gets attacked by MS. And when MS attacks the neuron, it cracks it open. And then all the stuff inside the neuron just like spews out into the brain and floats around and eventually finds its way to your bloodstream. And the stuff in that neuron are all these different chains. There are heavy chains and medium chains, and there are light chains. It turns out that the amount of neurofilament light chain in the spinal fluid or in the bloodstream correlates with how damaged your brain is. So the higher the neurofilament light, the worse off things are. And it looks like in MS, that might be a way to predict an attack or predict a response to a medicine. And so it's really, really exciting conceptually that we could check a blood test and say, you're not responding to your medicine before you have an attack or before you have a new spot. Now, it's not yet prime time, and there's some really big hurdles that we still have to overcome. For example, as a human being ages, their natural neurofilament light increases. So we need to know the changes from age, as an example. We need to know the normal range of humans. There's a lot of research ongoing looking at neurofilament light chain in the spinal fluid and now, fortunately, in the bloodstream. And it's my opinion that if we continue on this trajectory, it may be something available in clinic in only a couple years. Now, it's not the only cool biomarker out there, but it's the one that I'm probably the most excited about. Dr. Throw, what are your thoughts on NFL?
I agree with all of that. I think it's really exciting. It feels like we've been teased with it for a few years now. It's like it's almost there. It's almost there. And finally, I think it really is almost there. That be a tool in our toolbox to help us sort of determine how effective therapies are. Use it as a sort of prodromal marker when it's something about to go bad. I'm excited as well.
Question from the audience.
You guys are talking about all of these studies. If we're not currently a patient of the Boster Center for MS, are we able to get in all of these studies, or how would we do that?
That's a great question. So you don't have to go to the Shepherd Center or Boster Center to receive care. We have a lot of colleagues around the country that are outstanding. And her specific question was about participation in clinical trials. You don't have to necessarily be a patient at a given center to participate in their trials. And so it's not uncommon. Let's say that someone is cared for in near where Dr. Thrower is, and they find out, hey, he's doing a trial that my doctor's not doing. his doctor will be very comfortable referring to give that patient an opportunity to participate in Dr. Thrower's research. And we all feel that way. And so that's actually not uncommon. And what you can do is you can reach out to the societies, or you can look on the government websites, or you can look on the individual places like the Shepherd Center or my center has lists of what we're doing. And you can contact us and we'll try to help you. And what's really cool, if I can brag about our field, is we support each other. And so if someone from Atlanta contacts me and says, hey, I want to do a trial with you, I refer them to someone awesome local to them. That's a very normal way that we behave with each other. So you don't have to be at that location.
So you can go on clinicaltrials.gov, and if you go look under MS, you'll see all the studies that are going on all over the United States. So you usually have the research coordinator who's running that. They'll have some basics about the who's a candidate for that sort of trial, so you can see if you're a candidate. Just to kind of take that one step further along, the lines of participating in what comprehensive centers offer, maybe without being a full patient there. So a lot of centers, these ancillary services that we offer. So we have a wellness program, we have driving evaluations, we have all these different things. A lot of times you can participate in those ancillary services without actually being my patient or Dr. Boster's patient. So to look into that, we have, for instance, our counterparts here in Atlanta, across town, MS Center of Atlanta. Maybe we have a service that they don't offer. We're absolutely fine with their folks coming over and using our rehab, wellness services, whatever, without actually being our patient.
We sometimes call that the once-over. So you'll come by and we'll do all our stuff and put together a package of information and then give it to you and your team to take back so you can be awesome.
All right. Thank you. Well, she thanks you, but I'm not in front of her to hear, for you all to hear. But she's saying thank you, okay? All right. Next question from the audience, and we got about 10 more online, okay?
Can one or both of you talk a little bit about spoon theory and what MS patients can do to increase their spoons?
You want me to do it?
Spoon theory.
Take that one, Aaron.
So spoon theory was invented by a woman with a different autoimmune condition called lupus, which is also has a lot of fatigue. And I find spoon theory to work in the setting of MS perfectly. All right, it's a concept that you can use to explain to your family about energy. And the idea is that a spoon is a unit of energy. So when you wake up in the morning, you wake up with all the spoons you're gonna have. And as you go throughout your day, you spend spoons. So let's say I wake up with 100 spoons, and getting up, taking a shower takes a spoon, and getting my kid up takes me 3 spoons, and getting him fed takes 3 spoons. And I'm using spoons as I get through my day. Driving to work takes a spoon. But in the setting of MS, you wake up, and you don't wake up with 100 spoons, you wake up with 15 for the whole day. That's your energy. You got 15 spoons. Good luck. And it still takes a spoon to take a shower, and it takes 3 spoons to get your kid fed, and it takes 2 spoons to get to the car, and it takes a spoon to park your car. But the problem is you just got to work and you only have 8 spoons left. And when you use them up, you don't have any more spoons until you take a nap. And it's a way that you can help explain to someone, I'm out of spoons right now. It helps them understand that you've used up your energy reserves. Your functional reserve is not as big as it used to be, and you spent it all. It also helps you understand how you can bank spoons. So you get a honey-do list. You're supposed to do the laundry, the dishes. You're supposed to do the shopping at the grocery store and prepare for a dinner program tonight. Well, you know that if you do that, the next day you'll be in bed. You'll pay the devil's price. So you say, okay, I'm not doing the shopping. I don't need to do that. I can wait until tomorrow to do that. I'm going to bank that. That way I can save a spoon for that dinner program tonight. That's spoon theory.
I think with that spoon theory, the thing that we see in MS that we have to be careful about as well is so let's say you're a 20 spoon a day kind of person. That's your average energy level. And let's say you wake up one day and you feel great. You're having a 30 spoon day. There's a temptation sometimes to say, well, I'm going to do a boatload of activities today. I'm going to spend 50 spoons today, not realizing you're doing it. Well, realize you've just withdrawn from your account for the next day. And so it seems sometimes in our MS community that some of our folks come in 2 speeds, 100 miles an hour and asleep. And sometimes when they have a good day, they want to do that 100 mile an hour thing. That's where therapists that work in energy conservation can teach you how to kind of bank those spoons. No, don't use up today's spoons and tomorrow's spoons because you're going to pay for it in one way. So just be aware of that. I've often thought that God has a little bit of a sense of humor in giving people who might be very type A individuals, they're go-getters. Now I'm going to give you a health problem that is unpredictable and associated with a lot of energy issues. It's almost a kind of a cruel trick of nature to put those two things together.
If you want to, just as a very quick guide mark, keep this in mind. If you have an activity, an exercise, a workout, and the next day is normal, you probably didn't overdo it. But if the next day is not normal, you probably overdid it. And the reason I bring that up is that is not how we, living our lives normally, evaluate exercise. We normally make the evaluation during the activity. So if you had a good workout, that was a good workout. But in the setting of MS, I encourage you to pay attention to the following day as a metric of, did I overdo it?
And just one little side note, just in this, not quite spoon theory, but it kind of ties in with that. When you think about your exercise programs, a lot of us are so hung up on exercising to a metric. We're going to do 30 minutes on a treadmill, or we're going to do 20 repetitions at a certain amount of weight. Realize with your MS doesn't care about your metrics. And so with exercise programs, give yourself the grace to learn to listen to your body. Work with a trainer or a physical therapist to learn to listen to and learn to exercise to what your body is telling you to do. So you may have a day when you have 5 spoons, but you still want to do your exercise program. One of the things I've learned from our therapists is that we're creatures of habit with our exercise programs. You may have so little energy one day that you're not going to be able to do your usual exercise program. Sometimes just showing up, driving to the gym, walking downstairs and looking at your treadmill, that may be all you do for that day. It's keeping in the habit so that you don't break that routine can be just as important to maintaining your health over time as exercising to that hard metric.
He said magic words. Presenteeism counts. So this is not high school track practice, all right, where you're trying to beat your buddy. If you put on the Lululemon and you get on the treadmill, I give you full credit for that day's exercise, whether you walk or not. Seriously. Presenteeism is what we're looking for.
Yep.
Next question. What's the best way to help with balance? I just had a major fall that wasn't related to my walking. I just lost my balance. Are there any special exercises I can do for that?
Physical therapy, and more physical therapy. Get yourself evaluated and know what it is. Is it sensory ataxia? Do you need a good core strengthening program to help with that? But you kind of need to know what the problem is so that you know how to best design a program to push back on it. I'll put in a shameless plug here for a form of therapy that gets probably not as much attention as it should. It's not always the most accessible, and that's hippotherapy. Physical therapy on horseback. If you have access to it anywhere, they're not always that available, but it's a great form of core strengthening and balance training, and it's just fun. If it's a certified physical therapist who does hippotherapy, your insurance will also potentially pay for it for you.
Vestibular physical therapy can be very helpful. There isn't a pill for balance, but physical therapists can make you walk safely. They're amazing. And so that's the pill for that ill, and it's an effective pill.
Thank you. There have been several questions by different people asking why their doctor would be hesitant to prescribe medicines for fatigue or attention or balance. There are other people that have said things that are related to why a doctor wouldn't prescribe for a DMD for a person that's got relapse remitting clearly and diagnosed with that. There's another person that's asking why a doctor would not want to do an MRI and don't believe in them because they're saying that lesions are not counted anymore. And for all of this, before you guys answer, I want to tell each of these people, find a new doctor.
Yeah, so Stuart actually answered the question. So if you hired a plumber and he started to tell you where to put your sink, you would dismiss him from your home, right? And you'd find a different plumber. And the relationship with your MS clinician is an intimate relationship. It's an intimate relationship. We're gaming out how to live your life. And if you don't connect, you need to be able to have enough self-advocacy to say, I don't agree with you. You know, it's my brain, it's my body, it's my insurance money. I would like an MRI, please. And if you can't see eye to eye after trying to talk to them, look for a different plumber. Look for a plumber who will put the sink where you asked. I'm not proud, and I'm not for everyone. And so if we don't connect, I can't help you the way that I want to help you. I need to get you in front of someone who you connect better with, because it's not about me or us, it's about your MS and helping you live your best life. I need you to feel confident enough with yourself that you can say, no, doc, I don't really, I need you to hear me. I need you to hear that I'm hurting and I want you to do something about it. And if you're not comfortable, can you refer me to someone who can?
Yeah, I agree 100%. And so I tell our folks, you know, that our team here is here to be your guidance counselor. We want you to know what we know. We want you to make an informed decision. I want you to have all of the information in front of you. You may decide something that I don't necessarily agree with. If, as long as I feel like you've got all the information, you're a competent adult, I can live with that. I just want to make sure that you've got all the information. If you're not getting what you need from your healthcare team, like Dr. Boster says, is that there are plenty of other teams out there to help you get what you need.
You only get to do this one time, and we manage the only untransplantable organ system. And so we you know, be selfish. It's your brain.
Yeah, you don't get a do-over.
Thank you. I just eliminated 8 questions with that one.
Hoorah.
All right. Next, and this is very interesting, and I never thought of this either, but a person is writing, and this probably applies with most of us. When we were young, we used to get lots of ear infections, sinus infections, strep throat. We used to get sick a lot in school and otherwise. So it was always thought that your immune system might be low. So why is it now all of a sudden overactive that we have MS?
So if you look at it, you know, I think Dr. Boster said this earlier, in general, people with MS on a whole probably have fewer infections throughout most of their life. Just what the story I hear a lot is there's a common cold going through the family. The person with MS may be the last person to get it, or they don't get it at all. And that may be a function of that relatively overactive immune system. When we look at childhood infections, I don't think there's been any absolute trend to say that people with MS have more strep throats, more of the common stuff. Epstein-Barr virus, whole different animal. So we were talking about the Stanford research recently with Epstein-Barr virus. All humans are exposed to Epstein-Barr virus. It looks like in MS, it's a timing issue, and it's what the Epstein-Barr virus does to your immune system and sending you down this autoimmune pathway. But yeah, I think the take-home message is it's important for people with MS to realize is you are not immunocompromised. We may do something with our treatments that could immunocompromise you, but MS all by itself, you are not immunocompromised.
Thank you. Next one. How does a person know when they're getting the perfect dosage of certain medications such as baclofen for spasticity in their legs, rather than getting overwhelmed by it and getting so weak when using it?
So the best way would be that tricorder I referenced earlier with Bones McCoy, where you could just scan them and then it would just tell you, 30 milligrams in the morning and 15 in the evening, and we'd be done. I looked on Amazon, I can't find the darn tricorder. And so instead what we tend to use, and I'll use the baclofen spasticity as an example, is we use that first thing I told you about, asking the human, because they're a them expert, and the outcome is functional. So if you can sleep through the night without having spasms that wake you, and you can get up in the morning and bend your legs adequately, and you're not a zombie, then we probably found the right dose of baclofen. And it doesn't happen overnight. So when I start someone on oral baclofen, there is a process which lasts a month or two, dialing it in, where we have to first check on tolerability in the evening before bed, and then once we establish that, we bring a small dose in the morning, and we see about, and it's a process. And that dialing it in is a bunch of discussion with the human being. Are you floppy? Are you falling? Is your core caving in? Are you having trouble thinking? Are you having spasms? It's a functional outcome.
With baclofen, I always tell our folks that we're going to go slowly up on the dose of baclofen until one of the three dwarves visits you. It's either going to be sleepy, happy, or floppy. And so we prefer happy. We want happy to show up. If sleepy or floppy are showing up, we got to back off.
I'm going to steal that. That's good.
That was very good. All right. A couple of questions remain. First one, a person writes, how do we find doctors like Boster or Thrower in our own towns? You get on the plane and you fly to them.
Your local chapter of the National MS Society, MS Foundation, MS Association of America, those are oftentimes great resources for the who's who in your community. You can touch bases with national organizations like MS Views and News, and they can connect you with someone in that area. There's several different ways to do it. Another way to do it is to go to a local support group and listen, and they'll talk about who they like and who they don't, and who they get along with, etc. So there's several avenues to identify the doctor that fits you well, clinician that fits you well.
No, I totally agree. I think those support group things. There's also a website called vitals.com. You have to take it with a grain of salt, but it is real consumer reviews. So you can look up a doctor and real consumers have written in. Realize any doctor can make any person mad from time to time. So if you're looking up a given doctor and you see one bad review, I take that with a grain of salt. If you see 30 bad reviews, that probably means something.
All right. So that being said, I'm going to get up here for a minute because I want to thank doctors Boster and Thrower. I want to thank MS in the human body. I want to thank you all for everything that you did today. There were so many people online, and so many of them wrote in their thanks for this kind of program. And I just want to let you know that MS Views and News is a patient advocacy organization. We have MS. I have MS. I'm the president and founder of MS Views and News. I put this thing together to do basically exactly what we did here today, all right? We want to provide the best information that we can for the multiple sclerosis community. We do this with all of our different program series. And so I want to thank everybody that was here today. Again, I want to thank our sponsors. Our title sponsor, again, was Bristol-Myers Squibb. We also had silver sponsorship from Sanofi. And, it was my idea. Okay, it was my idea to even build the organization. But I can't do it without the people that were on here today, starting with Megan, all right? Megan she speaks at so many of our programs about so many different things, okay? Doctors Boster and Thrower also speak at most of our programs, and, they'll go around the country with us doing these programs, and that's exactly what we're trying to do. So we have a series called Encompassed MS Care, Reaching Rural America and Underserved Communities. So we do programs in inner urban areas around the United States that are not getting the type of information that they deserve to get. We get out to rural areas where getting on the internet is far more difficult than the problems we had today, all right? And we do those programs and we make it happen. We bring education to where people are not getting it. And so, I want to thank you all of you, for being here today. All right, this was great. And I want to thank the hundreds that were online and the thousands that are going to watch this afterwards. We already have doctors that are hearing from patients wanting to know why we can't do a program in their area similar to this. So, Dr. Thrower, you guys, and Dr. Boster, this was quite entertaining, okay, and very educational. And, I'm hoping that you guys can use it at your centers. And when they speak about patient advocacy, I was interviewed back in November by MS News Today, which is a big organization, online organization. And I never heard from them of when they're going to air the interview. And then 3 days ago, the person that interviewed me sends me a text and she says, it's going online in 5 minutes. Great. Well, where am I? I'm not even near a laptop, So I said, well, send me the link for it later on. And then we listened to it, and a lot of people I know listened to it, even when it was happening, because I put it on social media. And they got back to me saying that, they didn't know what my story was from the very beginning. It's a 45-minute interview. I think that is very, very good for all of you to hear, because it's why I do exactly what I'm doing and why I am here today, all right? Yes, I have MS, and I trained that MS shit to live my life, okay? Not anything else, okay? And so I will say it like that, but I will have to edit that word out later on, all right? And and we'll take care of that, all right? But seriously, y'all are only here for a certain amount of time. Don't let this thing beat you up. Take control, beat it, whatever you have to do. Listen to your doctors, listen to all your healthcare teams out there, and do something. And if you have a doctor that tells you you can't get an MRI because he doesn't want to give it to you, or he doesn't want to put you on a therapy, or she, or whatever, find somebody else. Get online, find somebody, all right? There's plenty of things to do out there. So again, everybody, thank you for being at this program. I want to wrap it all up and say goodnight and goodbye, good day, wherever you are in this world. There are people online from Europe, Canada, Mexico. Thank you very much for being here. Have a great one.
Thank you.